everyone. My name is Sarah Chown, and I am pleased to be moderating today's panel, The Voice of People Living with HIV and Treatment Decisions. I'm joined here today by 4 folks from across the country who play a huge role in ensuring that folks living with HIV are able to make decisions that are right for them when it comes to HIV treatment. So I'll introduce each person on our panel so you can get a sense of who you'll be hearing from today. We have Dr. Mona Lutfi, who is an infectious disease specialist at the Maple Leaf Medical Clinic and Women's College Hospital and University of Toronto. We're also joined by Hashem Ali, who is a peer navigator at the John Rudy Clinic as part of AIDS Vancouver Society. We also have a pharmacist joining us today, Harv, who is based at the Church and Wellesley Health Clinic and Specialty Pharma Solutions. And last but not least, we have Guillaume Thoreau, who is a research nurse at McGill University. So today's concept, each of our 4 panelists will be sharing an image that they've chosen to sort of help us as an audience understand some of the different folks that are involved in making treatment decisions, and in particular focusing on the role that people living with HIV need to be playing and get to play in making decisions about treatment. So each panelist will have the chance to share an image, describe it to us as an audience, and then have the opportunity to sort of share what that means around the role that people living with HIV have in treatment and what each of us can do, whether we're coming to this work as a clinician, someone who works in a community organization, someone living with HIV, or all 3 or 2 of those titles as well, and what we can do to really support people living with HIV in making treatment decisions that are right for them. So without further ado, I'll introduce our first speaker, Guillaume.
Hi.
Welcome.
So hi everyone. I'm thrilled to be a part of this meeting. I'm a research nurse and a clinical nurse working in Montreal. I think now they're gonna show my image. Yeah, so this is the image that I chose to sort of explain what I kind of notice in my everyday work clinics with the patients. I feel like HIV, it's sort of living with HIV, it's sort of a sort of a path, and you can either be behind the driver's wheel or you can be in the passenger seat. And what I think is important is I feel like I'm like, as a nurse, I want my patients to feel confident enough to get behind the wheel and steer it and not be passive in their life, meaning that they should, challenge the doctors, the nurses about their treatments. A lot of people just came in, they get their prescription, they don't ask for anything, they just sit there and they kind of watch as if it was a show, but it's not a show because it's their own life. So they have to get behind the wheel and start steering it. And it's not something that's easy to do. It takes a lot of communication, and also it takes a full team, not just a nurse or a physician or a pharmacist or a social worker from the team. You need to involve a lot of people to sort of encourage the patient to speak up about what he needs, what he feel is lacking in his HIV follow-up, in his healthcare. Does he have any side effect? Is it with the treatment? Is it posology? Is it something more cultural that bothers them? We need to empower them and engage them to you have to go behind the wheel. You have to take control of your life because, well, we only have one to live. And do you want to spend it on the passenger seat? Would you trust someone to take the wheel from you and just be sort of a witness to your own life? This is what I'm trying to do more and more now in my practice, to empower people to really take control. And if something bothers them, you have to say it, and you can't just be quiet, and don't want to bother anyone, and everyone's busy in the healthcare system because it's well, in Quebec anyways, it is public system, so we don't have we can't always take all the time that we would like with a patient, because sometimes I would spend a whole afternoon with just one patient, but it's not the reality that we live in. So that's what I wanted to say, and this is what I'm sort of aiming for in my work, and in my relationships with my patients, and also with the whole staff that I'm working with. That was my image, and this is how I wanted to share it with you.
Thanks so much, Guillaume. I was wondering, just as a follow-up, if you might be able to chat a little bit about what are some of the specific strategies that you've used when working with patients to really help them take that steering wheel and feel empowered. And just to let other panelists know, I'll give you a chance to answer that question too, should you wish. But we'll start with Guillaume.
I think for me, it starts with showing an interest in them. You have to ask questions, and you have to sort of get a feel of who they are, where they come from, what they love, what they hate, what they believe in. And it's after you have to genuinely put yourself in the person's shoes. And it's not something that you can do in one session. I think it's a long-term process. And I think it's the beauty of building a relationship, because you want to surround yourself in life with people that you get to know very deep and well. I think it should be the same for healthcare. I don't think you should be switching healthcare professional or pharmacies all the time. You have to stick with the person that you got to know, because they know you also well, and they could anticipate not needs for them, but you build trust. Basically, that's what you do. So this is how I'll start. I ask a lot of questions. Oh yeah, what do you do for a living? Blah blah. What Netflix show do you watch? What did you do during the pandemic? A lot of personal. Oh, you go to church? Which one? Oh yeah, okay. And you sort of get into it, and you show an interest. And this is how I think you build the trust, and it makes the communication more fluent with less barriers. This is what I do.
Thank you so much for sharing that. And I think that's a really important reminder for all of us, is that sometimes we can really get focused on the specific ways that HIV can show up in the lives of an individual, and sometimes forget about the fact that folks might have a favorite Netflix show, or be a really big part of a church community, or in the work that I used to do at Youth Co, be part of a 4-H club. And so I think trying to get a sense of how HIV might fit into the lives of a person might be different than what we might see as people who are providing services. And that's a really great reminder, I think, for all of us. Is there anyone else on the panel who wanted to jump in about what are some of those strategies that we might be able to use in our daily work and our relationships with people living with HIV to really empower folks to be in that driver's seat, when so often we know the experience doesn't necessarily feel like that?
If I may just jump in here, I think it's a great image of a driver being in a driver's seat or being a driver. But the important thing to remember is that you need actually there's a process of becoming a driver. You don't become a driver right away. You get your learner permit first, and then you have your kind of new driver sticker, and then you actually become a driver. And historically in the healthcare system, it's kind of a hierarchical system where there is an imbalance between kind of physician, nurses, and different providers and within the healthcare system. And the patient was always kind of a passive role, historically at least. Now we have changed to a more inclusive or a more collaborative strategies. So I definitely like the idea of empowering the person by getting to know them personally, and not just as a kind of just a patient and their health card number, but as an actual person. But it's just to be patient with them, because it does take time to develop that and to actually empower somebody to actually speak up and take charge of their own healthcare. Because like I said, we're dealing with a lot of historical issues in terms of how we deliver services in general. Thank you.
Yeah, thanks so much, Hashem. And I do think that one of the things that we know about the care that's provided to folks living with HIV is that some people get to go through a long period with the same healthcare provider, where that relationship is really going to look different than when folks are needing to access care with a different clinician or a different community organization every sort of time. So there might be some conversations that don't make sense on the first visit as folks are just getting to know each other. That might make sense weeks or months or years later. Is there anyone else on the panel who wanted to jump in on that specific question?
Yeah, if I may, I mean, to echo the exact sentiment as Guillaume and Hisham, the idea of building that relationship, that rapport, is a reminder, to myself that you're not just treating the condition, but you're also, treating the person and developing that that real important aspect of healthcare. It's beyond medication, after all. And I'll save the other bits of my answer for my segment.
Thanks so much. Dr. Mona, I'm sure you have lots to say on that. I'm going to ask you to just share any reflections you have on that question as part of your presentation or later on in the panel, so we can hear from Hashem. Hashem is a peer navigator and a person living with HIV who's done really incredible work. And I've gotten to see some of that in the role that I've played in the response in Vancouver. So I'm really looking forward to hearing from you today, Hashem.
Thank you, Sarah, for this very kind introduction. Like Sarah mentioned, I am a peer navigator at the John Rudy Clinic in Vancouver. I'm also someone who's been living with HIV for 20 years now. So I've had quite an experience and switched between different regimens of medication throughout my journey so far. I apologize for my lighting today. It still seemed to be Zoom issues. And also, it's the first time in Vancouver, just my luck, we have sunshine, which is unusual, but so that's why I couldn't have the blind open behind me. Anyway, if I could share my image, please. So I chose that image, which is basic. It's called the judgment hole. And it's basically, I'm from Egypt originally, and I kind of chose that image because I always try to do, whenever I am kind of faced with any issues, try to answer the 3 questions that are important in life. And part of that could be about your health as well. So this is the hole of judgment, which is the judgment of Ma'at, who is the goddess of truth and beauty. And what happened is your heart is weighed against that feather of truth. And you're asked 3 questions. The first question is, have you found joy in this life? And part of having joy in this life is to have a full life, including your health, of course, and to live a full life, basically a fulfilling life. The second question is, has your life brought joy to others? So you could have a good life, but you could have made others around you miserable, which is not good. So you should always try to at least make life easier or life good for other people around you. And the way I see this in relationship to this discussion is your discussion or collaboration with your physician or healthcare provider should be collaborative, should not be confrontational, should not be done in a way that's disrespectful, but should find a way or find a relationship that actually works for both parties and take it from there. And the third question is, have you sought knowledge or the truth? And of course, you need to educate yourself. You need to actually know, not just be a passive recipient of instruction, like Piami said in the previous slide. You need to actually take charge of your own healthcare. And part of that is to actually try to educate yourself as much as you can, or seek at least trusted information sources and move on from there. So your physician or healthcare provider have a great technical knowledge, but you also have your body 24/7. So you are the final arbiter of your own health, and you know your body well, and you know what works, doesn't work, and also you know your life well. You know what works for you or your lifestyle, your own person, and you take it, get as much information as you could, and that's how this relate to this discussion. That's basically it for my image. I'm really been fortunate to work in a very interdisciplinary environment. So I work in a clinic that include pretty much every discipline, from social worker, nursing, physicians, and other healthcare providers. And I've really seen in practice what patient-centered care means and how it actually functions in practice. There are still sometimes some challenges because, like I mentioned earlier, historically the system has been hierarchical, has been kind of top-down heavy, and kind of like there were no input from the patient usually. And also, if you are newly diagnosed, it's kind of overwhelming at first. If this is something new, you may not know everything, and it takes time to actually be comfortable and start to learn about different things. And of course, we have different challenges in terms of, I always tell somebody, you don't need really to be an expert in medicine or like in the medical field, but you also are required sometimes to be an expert in legal field, because we have non-disclosure laws, and that there's a lot of other burdens that's on you to actually educate yourself and take charge of your own healthcare. So it's kind of a evolving process, and I'm glad that most physicians, most clinicians are on board with the concept of having the patient input being taken into consideration, and that really makes a huge difference, because there's no need to like get a medication or get something doesn't work for your lifestyle, doesn't work for you, and it's important to realize, at least, this is something that's chronic. You'll be living with it for the rest of your life. So it's important to have something that fits your own life, and also explore like if there's other alternatives, for example, like then the medication first prescribed, if something best suits your lifestyle, because some medication may have like different scheduling, different requirement in terms of food, no food. So we need to be comfortable with something that actually fits your own life. And that's it for now.
Thanks so much, Hashem. One of the questions that I had in sort of thinking about this is, I think we don't often hear the word joy and the word HIV in the same sentence, let alone paragraph, or paragraph, let alone sentence. And I'm wondering if you might be able to offer some maybe specific ways that joy and treatment decisions, or joy and HIV, can be connected, because I think we especially in more clinical spaces or more population health spaces can sometimes really struggle to put those two together.
Yeah, and that's a valid question. I think joy, having a good and being in good health is part of leading a joyful life in general. So that's how I see it. Having to live with HIV, you need to fit it in your life and make sure that you lead a healthy life. And part of that is to make sure that you're on the right medication, something that suits you best. And I really see HIV as any other chronic condition. So there is no need not to be joyous about it, but you have to find joy in your life, whatever life is, or whatever life deals you. You have to actually find some sort of the positive out of it. And that's, I guess, how I also deal with the pandemic as well. It may not be it's not the best of times, but you have to do, kind of, if life give you lemon, make lemonade kind of situation. So you have to find the joy in your life, and part of that is lead a healthy life.
Yeah, thanks so much. So I think that maybe that connection between, in some ways we need physical health in order to experience joy in other parts of our lives, perhaps is part of what you're sharing. And I think, one of the things that is really important to me as someone who is HIV negative in this work is to really think about how we stop making comparisons, I think, or using sort of lazy language around saying that a person is healthy and therefore HIV negative, and an unhealthy person living with HIV, which is something that can come up sort of accidentally or subconsciously. And so one of the things that I really appreciated about what you shared today, Hashem, is that piece around the connection between health and living with HIV, and really wanting to reinforce that concept, and knowing that health is really connected to our ability to experience joy. which in different cultures is really prioritized in different ways. So I really appreciate that you brought that into the work today, and would also like to remind folks that finding joy is a thing that a lot of Black feminist scholars have really talked about recently, including Adrienne Marie Brown, who has a really great book called Pleasure Activism, that sort of talks about what is the role of pleasure in our life. And it's not connected to HIV specifically. It does have quite a great chapter on harm reduction work. But I think the idea of bringing that into these spaces that sometimes can really feel removed from joy can be really helpful, both for clinicians that might be having really long and busy days, but most importantly, the patient who might be sitting on the other side of a desk from a clinician in that way. The other follow-up question that I had for you, Hesham, was really around, you mentioned some pieces around knowledge. And so I think, I don't have the exact words that you said, but I believe you said something about not needing people living with HIV to become medical experts, but needing to maybe become experts in some of the other areas where HIV really impacts the lives of people living with HIV, including the unjust laws around criminalization of HIV non-disclosure that currently are in place in different ways across the country. I was wondering if you might want to either reflect, I have two pieces of this question, so you can choose one or both, Hesham. But I think one is really around, what is the role of clinicians in navigating the medical education that a person living with HIV might have? And then the second question would be, what might you see of the role as a clinician in helping people living with HIV become experts in areas of HIV that folks might want to? So, folks might be very interested in research, and I know we have a number of folks on the call today and at CAHR in general who might be in that boat. But then we also see, folks living with HIV becoming experts in peer navigation, in the law, in advocacy. So I'm wondering if you might want to reflect on that at all.
Yeah, sure. Thank you, Sarah. What I meant by, you don't need to be an expert, but you need to at least have basic knowledge about your health, your medication, how that affects your life or relate to your life. So a clinician may suggest, kind of trusted sites because most of patients I deal with are usually going on the internet all the time, and everybody's out there. But there are all kind of either information that are inaccurate and cannot be trusted, or on the other hand, if you actually do find the right information, it's probably not written for you, it's probably written for other clinician, or it's part of research. So it's important to keep that in mind, because sometimes it can be overwhelming. You can deal with like very specific issues that if you don't have really the medical background, it can be quite overwhelming and also frightening sometimes, because it's not really talking about you, it's talking about a specific case. So it's important for clinician and for the patient to actually know, or the clinician to suggest to the patient certain sites or certain publications that are trusted, and simplify, the information for them. Because again, not everybody, have the medical knowledge or even legal knowledge in the case of non-disclosure, but they need to have at least some basic right information, and that can be provided by clinician, by making sure that they have that knowledge beforehand. You don't need to be an expert, but at least you need to know that you have certain rights. For example, right, you have your right over a person, so you're not really forced to take anything like any treatment or any medication without your consent. That you'll always be consulted before any procedure, and you'll always be given the information, and then you can actually make up your own mind about, based on that information, about how to proceed next or what works best for you. Yeah.
Thank you so much. I know I gave you a lot to think about in that question, which we might get the chance to come back to towards the end of today's discussion. Next up, we have Dr. Mona Lutfi, who often goes by Dr. Mona. She is an infectious disease specialist and researcher in Toronto.
Thanks so much, Sarah, and thank you for having me be the Canadian physician on this panel to share my experience. As you mentioned, I'm a physician. I see people living with HIV in Toronto and also Saskatchewan. And I'm also a researcher. And pretty much all my academic research is done using principles of community-based research. So that means I involve people living with HIV and follow GPA and MIWA, so the greater involvement of people living with HIV and the meaningful involvement of women living with HIV, because I work mostly with women living with HIV in my research. In one of my projects called CHIWOS, the Canadian HIV Women Sexual Health and Sexual and Reproductive Health Cohort Study, we got funding for the peer research associates in the study to design their own knowledge translation materials for the study. And one of the peer research associates made an anthology. And that anthology is actually being launched at CAHR this week. It's poster abstract 169. And I'm going to share with you actually one of the poems that is in that anthology. So maybe if you can put up my slide. I'm not sure you can read it clearly, but I'm going to read it for you. This is a poem that was written by a peer research associate that I work with, who's amazing. She's an incredible artist, Brecklyn Bertozzi. She's from Hamilton, Ontario, and I just love this poem. The title is "Real Queens Fix Each Other's Crowns." When the crown is in your possession, supporting others is your secret weapon. Using what you have and what you know can make a difference in someone's life and help them grow. Empathy, understanding, and compassion are some of the greatest traits. They help rid stigma, misconceptions, and hate. Being there for each other in the hardest parts of it all, picking up one another when we fall, being an advocate for change and good health for our peers, and a phone call away or even wiping a few tears. Sticking together and forming a tribe, this work can fill a woman with so much pride. Real queens fix each other's crowns and support each other in our ups and downs. So while this poem is really about peer support, it also speaks to me and how I feel that about the features that are so important in being a care provider to people living with HIV. And it also really highlights the importance of peer support. What this poem really says to me is that the most important person in making decisions about treatment is the person living with HIV themselves. They're the ones that's wearing the crown. They're the queen. So in my opinion, they're the most important person. And for me as a care provider, I'm there to support them, to give them the information they need to make the decisions. You asked in terms of what Guillaume was talking about driving the car. How does someone drive the car? Well, it's my job or our jobs to help with medical literacy. So to give them the information that they need to make decisions. And so this is called person-centered care. Hisham already referred to it, also known as patient-centered care. So this is seeing the patient as a whole person, asking them about what the most important items are in their lives. It might not be medication treatment. It might be housing, it might be food, it might be their family, getting to know them, seeing what it is. But then also, maybe it does relate to treatment. What are the most important features about treatment? Is it pill size? Is it number of times a day? that a medication is taken, really a person shouldn't be living with any side effects. So knowing if they are having side effects, and to create an open environment for them to share if they are, or to share anything that they want to in that care provider patient relationship. And this leads to the really important concept of shared care decision making, so that the patient can make their decision with the information that I'm providing. And as Hisham said, it's the person's right to make the decision for themselves. Again, this poem to me really stresses how important peer support can be. Whenever I can, whenever I have a patient who's newly diagnosed, or who doesn't have supports, I try to connect them with local aid service organizations or peer navigator programs. These programs have been shown to be incredibly helpful and supportive, and I've seen incredible benefits. And I think we've all spoken, and you can see by the panel, and I think our next speaker is going to speak a little bit more about it, is that the multidisciplinary team is so important. It's not just the physician and the patient, but the nurse, the social worker, the peer navigator, and all working together to make that, as Hisham said it, joyous experience possible.
Awesome. Thanks so much, Dr. Lutfi. I think that poem was so great to be able to share. And at this point, I'm really seeing that we have a few different metaphors around what this experience might be. And I think that really speaks to both the fact that there's similarities, of course, across these experiences for folks living with HIV. There's also some differences. And then similarly, depending on the setting where we're working, depending on our role that we play, we might be positioned differently to some of those metaphors. So as we sort of continue the conversation today, I'll invite folks in the audience and folks on the panel to really think about which of those metaphors, how they might connect to each other, and which of those might make the most sense in our own work that each individual in attendance today might be doing. Was there any sort of initial comments or thoughts that came to mind as Dr. Mona was speaking?
If I may.
Please do.
A great image, and I'm actually very familiar with CHIWAs because some of my colleagues and some of the people, great women I know and work with, have the privilege of working with, are actually part of that study and been doing the peer research associate role in Vancouver, or at least in British Columbia. So it does resonate with me that this is, of course, you are the center of attention or the center of care, but you also need support around you. You cannot be, kind of not, isolated, or you cannot be completely cut off from the rest of a support system, because that's really, really important to have like somebody or people around you who actually are part of your support. And to go back to the image of the driving seat, you need actually somebody who's a mechanic. You need someone who's, someone who teach you how to drive. You need, so there's a team effort. It's not necessarily that you'll be just grab a key of a car and just start driving right away. There are a lot of people involved in that process before you actually can drive. So I like that image, and I like also the image of or the poem, which is actually very, very touching as well. And I'm glad that you see the value of my work or peer navigation in general. I kind of not plugging my work here, but I really see it as valuable because it does help people, especially newly diagnosed, gain the confidence and the knowledge to actually go on with their life and actually know that there are options. There is life after diagnosis, and it's not a death sentence like it used to be in the past. So that's a good thing to know. Thank you.
Thanks so much, Hashem. And I know that you're not here to plug your work today, but I think in a large way, a lot of us are here to plug your work today as part of the team of folks that it takes to really support people living with HIV and getting to make treatment decisions, which, you know, in some ways we would really love to be there where that is true in the case of every person. I mean, we know for lots of reasons that that's not the case today. And we also know that there's so many folks across the country working really hard to make that happen. And one of those folks is Harv, who is a pharmacist, and we'll be chatting next. And I think really bringing this together to really highlight that role that each person in a team gets to play, whether that's a clinical team or sort of that broader team that supports all of us in our lives, whether or not we're living with HIV. So the folks that are most important in our lives, including in some cases clinicians.
Yeah, well, firstly, I'd like to express my gratitude for you know, providing me this opportunity, you know, introduce and you know, explain my experiences in this field. If you could kindly post the image, that would be great. Wonderful. So I selected this image because in a broad sense, I think it illustrates the interplay of the various parties that influence a patient's healthcare experience and how we're meant to untangle the complexities in providing that experience. And, you know, you've heard from everybody today the value of each individual person and what they bring to the table in managing the care for our patients. In a community pharmacy setting specifically, the prescription, patient, payers, and community resources come together. And so there are a number of roles for the pharmacist to play, ranging from, you know, assessing drug therapies, preventing or mitigating drug interactions and adverse events, counseling patients on adherence and expectations of therapies, navigating third-party payer reimbursement, and including patient support programs, and to regularly review this at intervals. So I think this puts community pharmacy in a prime position to engage in discussions of treatment optimization with patients and their prescribers. And we typically see patients, you know, every month to every 3 months. And so there are opportunities where regimens can be reviewed for simplification, tolerability, interactions, and drug coverage. And all of these factors can change over time. So keeping an open dialogue with patients about new therapies can encourage them to initiate that discussion and you know, support them in making those informed decisions as well. And I should like to mention that the pandemic has challenged us in a number of ways to continue optimizing treatment, but the most significant is that we simply see patients less frequently in the pharmacy. Many refills are being delivered to help keep people safe at home. So the opportunity for in-person discussions are also limited. However, despite that, we still continue collaborating with specialists and talking to patients virtually so that, as the image implies, we can maintain those connections into care. Thank you very much.
Thank you, Harv. I wonder if there's anyone who wanted to jump in right away in sort of response to some of those pieces. And in particular, I think some of the shifts that we've seen around the ways that people living with HIV, the opportunities that even exist in the context of the pandemic to make those decisions.
Sure, I can share about what Harv spoke about. I really like the diagram because it shows the interconnection of the entire team. And I do want to say that the role of the pharmacist is so important. And I have found it to be even more important during the pandemic. I'm not sure how you feel, Harv, but, and that's because sometimes patients don't answer the phone when I call. I don't know why, but they see my name maybe and don't answer the phone. But they always communicate with their pharmacist. They always or usually go in and pick up their medication, or at least speak to the pharmacist to arrange delivery of their medication. So sometimes the only way that we can communicate with patients is actually through the pharmacist. So I really want to thank you, Harv, for facilitating that, but that is something that I've seen happen more during the pandemic.
Yeah, absolutely. I have to say it's been a struggle, to say the least, during the pandemic, because just seeing people is infrequent, and to just be able to make that connection sometimes for the patients to be able to reach out to their primary care prescribers or the specialists. It ensures that we can kind of keep those lines of communication open for them.
So we are just coming into the last stretch of our time together, and I know that I've really appreciated the conversation today. I just wanted to invite any sort of closing thoughts from our panelists as we begin to wrap up our time together and go back to, I think, the work that we all need to continue to do to really support the voice of people living with HIV in treatment decisions.
Can I, if I may, again, I really like the image, of course, Harv presented, because that it's not just show interconnectedness of everything, but also it shows that sometimes it can be complex. Not everybody can navigate easily through a system, especially if they're not familiar with it, and you need support in that. And so that's really great. And I really have a fondness for pharmacists in general, because I've worked with them very closely. And they've been great in explaining, like, different regimen, different option that we have right there. They seem to have a little bit more time than physicians, and they go over everything in very great details. And I was even convinced in BC, our HIV medication used to be outside the PharmaNet, which is our central pharmaceutical kind of database that every pharmacy have access to. And the reason was because historically, they were kind of afraid that people who are living with HIV may be shy or reluctant to fill the prescription from community pharmacies. So it was excluded from our database, and that was really the only exception. Over the last few years, I've been talking to pharmacists, and I've been convinced by the merit of the argument that actually, no, it should be actually included, because it can have a negative effect, especially when medication interaction and counterindication that community pharmacists have the same professional standard that everybody else in the healthcare system, and that should be actually included. And I've since taken on the cause of that 2 years ago, and last year actually the BC government included HIV medication in the database. So that's great, and I really credit pharmacists for kind of providing me with that knowledge and swaying me my opinion from one side to the other, because I was on the other side, concerned about privacy and the right of patient to not have their information disclosed. But I was really convinced by the strength of their argument and the merit of their argument. So yeah, and of course during the pandemic, they have been kind of the only link to patient, because everything has been done remotely so far, like including this discussion. And pharmacists have been the only link sometime with at least checking on a patient, because you still need to get some sort of a connection with a pharmacist to actually have the prescription filled. And if it's a final thought, I really think everybody within the healthcare system, including the patient, of course, have a role to play. And don't be afraid to ask questions and explore new ideas and new things. I'm sure physicians are actually been great, and everybody who really within the team has been really great in kind of getting new ideas, like the idea of U equals U, undetectable, even untransmittable, which is kind of like, it's a little bit of a brand new idea, and there's some challenges in getting your head around that. But everybody has been at least open to discussion and open to discussing that with the patient. And also, when we have new regimen coming in, I'm really grateful that we have new regimen coming in all the time. And it's not like just because we have it under control doesn't mean we can improve, and we can have even a less toxic or less side effect medication in the future, more convenient schedule, etc. So I'm grateful that that work is still continuing, and we're still getting newer medication available to everyone. And sometimes that it's a little bit challenging because, like, for example, I'm on a 2 drug regimen right now instead of 3, and that was also hard for me to kind of accept at first. But the way I explain it to patients sometimes is that, yes, we've been telling you all the time that 3 medication has to be 3 because HIV is very clever, cannot get beyond, like, if it gets one obstacle, it cannot get beyond the other, and then the third one. But I tell them, well, now we have a technology that the first obstacle is kind of like an encrypted 120 or 500 and 254-bit encryption. So that actually makes it harder. So therefore, it's easier for you. And thank you very much.
Thank you so much for those final thoughts, Hesham. And I think one of the pieces that you had talked about in there in particular around the role of healthcare providers in having conversations about undetectable equals untransmittable, or U equals U, is, I think, just another example of the types of relationships that can really develop when we're working in this interdisciplinary model and having these opportunities to understand what's most important to folks that are in front of us. And ViiV, who has sponsored today's session, has actually put out a poster that is available here at CAHR at this time, that's looking at the prevalence and correlates and health impact of the conversations that healthcare providers have around U equals U, and what that counseling might look like. So I really encourage folks to check that out, as well as a second poster also from the same survey of people living with HIV, called Putting the Heart Back into Heart, as in highly active
antiretroviral.
Thank you. Highly active antiretroviral treatment or therapy, the role of healthcare patient engagement in improving health outcomes among people living with HIV in Canada. So those are just 2 of the other posters that ViiV has today, and we really appreciate the opportunity that we've had to have this conversation with all of you, and would really like to invite you to send us your questions, and we'll do our best to have some answers to them. So as of now, we'll be going into a live Q&A session, and you can submit those questions through the Q&A box, and we will do our best to answer them. Thank you so much.